18-year-old male, posterior fossa hemorrhage in October 2010. Diagnosis of lower brainstem cavernoma. Radiosurgery in December 2010, 2 months later, at another service. Posterior fossa hemorrhage again in May 2011. Fully conscious with gait and trunk ataxia and neurosensory deafness on her left ear. This is her CT scan, axial cut showing a hematoma over here, posterior to the pons, lateral to the fourth ventricle. And this is her MRI showing at this stage this is a hematoma lateral to the medulla oblongata. So this is the location of the inferior cerebellar peduncle on the left side. But we go more superiorly, we can see that this hematoma or cavernoma occupies also the middle cerebellar peduncle. So this is a hematoma, probably due to bleeding of the cavernoma, that occupies mainly the left middle cerebellar peduncle, but it extends inferiorly to the inferior cerebellar peduncle. This is her MRI coronal cut. This is the inferior portion of the middle cerebellar peduncle, but extending all the way to the inferior cerebellar peduncle. One good landmark, it does not reach the floor of the fourth ventricle. And you see here, this is the right tonsil, and this is the left tonsil. So the majority part of the cavernoma is actually located on top of the superior border of the left tonsil. So if I can identify the left tonsil, I know that the cavernoma sits above the superior pole of the left tonsil. Here are the sagittal cuts of the MRI. Once again, here is the coronal cut, and we can see this is a right tonsil, left tonsil. So this is the dentate nucleus. So he underwent a left telovelar approach for this cavernoma. Here is the positioning of the patient and the in prone position, and this is the skin incision. So he underwent a midline suboccipital craniotomy with the left telovelar approach. So the patient underwent midline suboccipital craniotomy. Now he is in prone position and I am standing behind him. So this is the left tonsil, this is right tonsil, this is medulla oblongata, this is the lower cranial nerves on the left side, this is vallecula, the space between the two tonsils. So let's go to the video. So right now I'm cutting the arachnoid to separate to open the two tonsils, separate the space. This is choroidal plexus of fourth ventricle. This is a foramen of Magendie. So we are looking at the left side. We can see this, the brown color. This is not normal. We know that we have to go expose much more. So we have to free the adherences between the tonsil and the tela choroidea. And this is the choroidal plexus, tela choroidea. So I'm coagulating and cutting. Once again, this is telochloridea on the left side. You can cut it, you can coagulate and cut it. Telochloridea is not neural structure. So now I want to dissect the tonsil. We know that tonsil is free on top, medially, anteriorly, posteriorly, and inferiorly. It is attached to the cerebellum by the peduncle of the tonsil. So I'm dissecting and opening the arachnoid of the superior part of the tonsil. The peduncle of the tonsil should be here, but I don't have to go up to there. And then cutting the arachnoid superiorly, just like opening a sulcus or fissure, creating more space. As we go more laterally, we can see much better now. This is a cranial loop of the left pica, caudal loop of the left pica. So a little bit of pyramid has been removed to create more space. And then the surgery is not over yet. So exposing more, not to damage pica. I'm working between the branches of pica and going laterally and at upper part of medial and upper part of the left tonsil. So this is definitely not normal. So I'm opening, cutting. This is the cavernoma. Now, and this is the left side. This is the left stria medullary of the fourth ventricle. This is all left side. So I have been dissecting and went very lateral. You see, this is a brainstem. This is a medulla oblongata. This is a middle cerebellar peduncle. This is a midline. So you can see this is a midline. This is the right stria medullary. You see here, this is a left stria medullary, and then you can see the hematoma and the cavernoma occupying the lateral part, not the floor of the fourth ventricle, but the lateral part. That mainly is the middle cerebellar peduncle over here. So now I'm working on the cavernoma. But you can see this is very different from, you see the aspect, very suggestive of cavernoma. Recent hemorrhage the fresh clot will help you to dissect, to make a correct plane of dissection between the cavernoma and the peduncle. But this is an old, so it's more stuck, adherent, so it's more difficult to remove. But anyway, you have to work out this one of the probably the draining vein. And working, exploring, working around the cavernoma. And also this patient underwent radiosurgery. But I didn't find much difference between this and regular cavernoma that is bled before but did not undergo radiosurgery. The old hemorrhage is much difficult to operate because it's always very stuck. You know, it's sometimes not easy to distinguish what is the normal tissue, what is the the abnormal. If you can remove just by, you should not remove just by the color. You see, this is the cavernoma plus cavernoma has been isolated, and then now it's been removed. Once again, picture this is a midlines over here, midline. This is stereomedullary of fourth ventricle on the left side. This is inferior cerebellar peduncle, and this is a middle cerebellar peduncle. Midlines over here. Now this is the left tonsil, right tonsil, and this is the approach we did to get into to remove this cavernoma. Since the patient is in prone position, the blood, the water, and the saline solution will accumulate here. So that's why we use additional suction tube here. So every liquid, saline solution, blood that will fall into the deepest part of the craniotomy, I just placed a tube over the deepest part of the craniotomy, so it will suck continuously blood, saline solution. So we always keep our surgical field clean. So this is his postoperative CT scan showing the route we used to reach the inferior and mainly the middle cerebellar peduncle, with the apparently complete removal of the hematoma and also the cavernoma. He was neurologically unchanged after the surgery, and then he returned to his hometown, Rio de Janeiro, for rehabilitation and physiotherapy.